Good afternoon, doctors. On behalf of Torrent Pharma Prima Division, I take this opportunity to welcome all the doctors who have come to attend this CME program on constipation. Today we have Dr. N. Arun as a speaker. Doctor has done his DM Gastroenterology and Doctor works in Apollo Greenstone Hospital as a senior consultant gastroenterologist, hepatologist, and interventional endoscopist. Dr. N. Arun is one of the most experienced gastroenterologists in Chennai, with immense experience and expertise in managing conditions affecting the digestive system. Dr. Arun is adept at treating various conditions like acid reflux, liver cirrhosis, inflammatory bowel diseases, irritable bowel syndrome, and much more. Dr. Arun provides a dedicated approach towards analyzing the functioning of the stomach, esophagus, small intestine, pancreas, colon, etc. Dr. Arun offers extensive treatment for GI conditions involving symptom management and palliative care. Dr. ensures elaborate diagnosis for the treating all major gastrointestinal cancers and chronic gastrointestinal disorders. Doctor utilizes various assessment tools like endoscopy, colonoscopy, polypeptomy, and much more. In addition, Dr. Arun also performs extensive surgical procedures such as ERCP, EUS, and metallic stenting. Doctor also avails the patients of liver transplantation consultation. Today, I welcome Dr. Arun for the talk of constipation, chronic idiopathic constipation in Indian perspective. Over to you, Doctor.
Thank you, Team Torrent, to give me an opportunity to be here, and respected consultants to join in this occasion on this wonderful Sunday. That was the morning hours to bring a crowd and to make the doctors to sit in a session for almost around 30 to 40 minutes is definitely a big task now. And I would like to appreciate Team Torrent for this conclave which is happening right now. And today we have been chosen a topic called constipation. So what is happening in constipation based upon your Indian scenario? That's the most important thing for me to take into account. And every day we'll be tackling a patient with constipation. So how are you going to approach a patient? So you should remember the basic 6 things how to approach. What is this so-called constipation? That's number 1. Number 2, once you're going to see a patient with constipation, how are you going to clinically recognize that patient? How are you going to tie it up? Which means patient risk factors, how are you going to assess, and where are you going to map the disease, and how are you going to investigate, and how are you going to treat. And next to that, what are the various special occasions in which you need to consider your constipation? That's outline. I'm not going to talk much in the slides. Basic outline I'm going to discuss. Regarding that, so what is constipation? In case there are 2 modalities for you to diagnose this constipation. There are 2 basic classifications. One is functional constipation, and next one is based upon your organic causes. If you're going to look into that, the chronic idiopathic constipation will be the most common scenario in which you'll be experiencing more than 80% of the population. And next to that, the organic causes will be only around 10 to 20%. And our intention, as a gastroenterologist, as a physician, as a surgeon, when you're going to see this problem in your routine OP practice very frequently. So what are you going to do? Once you're going to get a patient, with most of the patients who are going to attend your OP, they will be taking multiple medications. Some patients will be taking bulk forming laxatives, and some patients will be taking other medications. Some patients will be on huge amount of molecules like your GA stimulators and all those things like your Procalibra. All those patients will be coming into your OP. But at that point of time, how are you going to recognize that? How are you going to manage that kind of patient? Is the most important thing to discuss in 30 minutes of my presentation. So how are you going to recognize a patient who is having constipation? So first, the basic risk factors. If any patient is going to come to your OP, you need to see whether the patient is having any basic risk factor based upon the age of presentation, based upon the sex of presentation. Female patients will be more preponderant to that. And next to that, look for any alarming features. Always in GA, alarming features are very, very common and very, very simple to remember. Bleed, In case if you are suspecting any bleed possibility, one red flag, and if the patient is having anemia, definitely a pointer. And if the patient is having evidence of any mass, and if you are going to palpate a lump in the colon. So these are all the basic alarming picture in which you need to look into that, whether the patient is falling into a red flag sign is there in the field of gastroenterology or not. So once you're going to see as a patient with chronic idiopathic constipation, it's one of the toughest entities. So simple definition to remember is, now the common entity what is called as functional GI disorder. Starting from your oral cavity, your upper esophagus, and from your stomach and to your colon, there are huge amount of list of causes for your functional GI disorders. That is very, very difficult to recognize and very, very difficult to tackle, because no single molecule being proven to be efficacious when you're going to manage a patient with functional GI disorders. So how to recognize that? That's a classification being taken into account in India. Huge amount of study being done in SGPGI for this, based upon Professor Dr. Uday Ghoshal guidelines. So that's what is called as Rome criteria. As you all know, the Rome has been evolved into multiple organizations, like from Rome 2, 3, and right now 4 is going on. What is the basic definition? Always you need to remember two signs. One sign is if you are having any difficulty in passing. If you have a rectal examination, you are going to have any sensitive finding if it is going to be there. These are all the pointers you need to see. What is the basic definition? The bowel movements, if it is going to be less than 3 per week, that's a simple thing you should not miss when you are going to see. If any patient who is going to present with less than 3 bowel movements per week, that shows that the patient may go for evidence. There may be hardening of stools, lump of stools, straining for edification, sensation of incomplete evacuation, and this consistency, this has to happen for a period of almost 3 months or a period of 6 months to duration, without any other major alarming picture you need to see. That is what is called as your Rome-based criteria to diagnose a patient with chronic idiopathic constipation. So once this kind of patients, if you are going to see in your OP, how are you going to approach such scenario? So the basic things is, so what is the basic thing? For your chronic idiopathic constipation, 3 major things are supposed to be taken into account. One is normal transit, which means the normal colonic transit should not go more than 50 hours. So one is normal transit and one is slow transit, and next to that is your functional defecation disorders. What is this normal transit constipation? It will be predominantly common in young individuals, male individuals who have been frequently depressed. We have been seeing multiple patients who are coming to OP with depressive presentation. So they will be having predominantly normal transit. Say they will be having urge. They may go first, but they will not be having urge. But the stools will be loaded with rectum. The rectum will be loaded with stools, and apart from that, the patient will be having the presentation to pass, but they cannot able to do it in a prompt way. The colonic transit, everything will be normal for that normal phase constipation. What do you mean with the slow transit constipation? Predominantly in case of young females. If the patient is a young female, at that point of time, in case if you are having diabetic presentation, diabetic gastroparesis or other things, the transit time will be more prolonged. So the stools will take much time to reach the rectum. So that is what is called as prolonged transit constipation or slow transit constipation. What is this defecated disorder? Defecated disorder means it's a dyssynergic defecation or function obstruction syndrome. So what is it called? For example, if any patient who is having obstetric trauma, sexual abuse and all those things, at that point of time, they may be having an urge to defecate, but they cannot able to defecate. They may assume various postures to pass the stool, but they cannot able to do. And always the rectum will be fully loaded with stool, and they may be having urgency. They will be spending too much of time in the toilet, but the stool is not going to come out. This is what is called as a defecatory disorder. To diagnose this is very complex. Is it necessary to diagnose all? That is one important thing we need to address. So how are you going to diagnose? Because the prevalence for normal transit will always mimics your IBS-C. Irritable bowel syndrome is a different entity in which you will be having various consistency of your stool, but once you pass the stool, the consistency may change, the frequency may change, all those things. That's what is called IBS. Among IBS, you should remember 3 major things. One is IBS-C, one is IBS-D, which means diurnal preponderant, and next one is IBS-M, which is mixed pattern. So this is different. And always your normal transit constipation will mimic your IBS type C like presentation, in which the patient will be having predominant presentation of abdominal pain. They'll be having abdominal pain, sensation, urge to defecate, change in frequency and change in form of stools. This is what is called as irritable bowel. So you need to diagnose whether the patient is having IBS type C or whether the patient is having functions, chronic idiopathic constipation with evidence of slow transit. All those things to look into account promptly when you're going to manage a patient with this kind of constipation, like presentation. Apart from that, as you consider, once you are going to diagnose this patient as normal or slow or evidence of defecated disorder, there are huge list of investigations of that. How are you going to procure the investigation? Before considering that, what are the various causes apart from that? As you all know, when you're going to do a patient, when you're going to see a patient in your routine clinical practice, you should not miss out any clinical findings. Starting from your head to foot, you need to analyze the patient, because we might be thinking the patient is having only evidence of a functional GI disorder, but that might be evidence of other things. Apart from the common secondary presentation, for example, you list of metabolic variants. For example, diabetes, starting from your hypercalcemia, hyperkalemia, all those presentations. Your metabolic variants could be a possibility to trigger your secondary constipation. Your drug abuse, your TCA, antidepressants, cardiac, opiates, so many molecules are there to trigger that. And apart from that, your metabolic and neurological focus. For example, if you are going to have a neural chip involvement, if you are having a tabes dorsitalis, other neurological focus, long-standing sequelae of any complication in neurology, at that point of time, the patient may be having evidence of constipation. So assessing the patient as a whole is very, very important to diagnose your secondary causes of constipation, in which in the armamentarium you list of causes. That's not the area to discuss, but you should remember that you need to think as an overall presentation, overall approach when you're going to manage a patient with constipation. That is very important. Once you're going to label that, if you're ruling out a organic pathology, so how are you going to rule out the organic pathology? So basic surveillance you need to do with your colonoscopy. So overall the patient obviously supposed to be subjected. Is it only colonoscopy be indicated or any other investigation? So many other investigations. Colonoscopy will be having evidence. It could be because of stricture or any growth or rectal evidence. How many complications are there? And you need to see a colonoscopy to look for evidence of organic pathology is there or not. But only colonoscopy will it yield your diagnosis for your chronic idiopathic constipation? Means no. In that, there are a huge list of focus of investigations in the battery. So what you're supposed to do that? The basic investigations will be your colonic transit time. We need to do your slow, for example, if you're tackling a patient with rectal slow transit constipation. So how are you going to assess this transit? You can do by a wireless motility capsule. You can do by your balloon expulsion test, for example, and next to that you can try by your scintigraphic procedure. So many other modalities of newer investigation and your MR defecogram, your barium defecogram. There are so many things are there which are being drawn into the field. So briefly is my intention, briefly outlining all those things, my intention to talk here. So these are all the various newer investigations being tried to diagnose this presentation, whether the patient is landing up with evidence of defecatory disorder or whether the patient is having evidence of slow transit constipation. What is this basics? So what is the basics for your constipation physiology? So once the abdominal pressure is going to get raised, at that point of time, what is going to happen? Your diaphragmatic contraction is going to get happen, and your puborectalis is going to get contract, followed by your levator ani is going to get relaxed, and followed by, at that point of time, your sphincter, your internal sphincter is going to get contract and slowly starts relaxing, and your external sphincter once is going to get relaxed, thereby your stool is going to come out. That's a normal physiology. In this kind of cases, if your sphincter relaxation is not prompt, if your colonic transit is not prompt, at that point of time you are going to land with evidence of your constipation. That's more common as the day, as the age, as it progresses based upon your various other presentations. So you need to recognize your constipation, whether it's normal or slow or other things, as what have been discussed in this flow chart. And basic approach you should not forget based upon your clinical presentation. And apart from that, how are you going to manage this patient who is having evidence of constipation? That's very, very important. So how to approach or manage a patient with constipation. So First, any patient, take a proper history, clinical examination, look for the diet pattern. And when you're going to give a diet, make sure your diet, fiber, that's to be done, physical activity, lifestyle modification, treat the coexisting comorbid pathology. For example, if the patient is having thyroid, tackle the thyroid. In case if the patient is having diabetes, control the diabetes. All those coexisting complications to be addressed strongly. And fiber, you should be soluble fiber of at least around 25 grams per day. The patient is supposed to get consumed. And all those things you need to tackle before addressing a proper molecule for constipation. To discuss about the various molecules, what is available for constipation. As you all know, the laxatives, it could be a huge list of laxatives. For example, your bulk forming, your osmotic laxatives, your stimulants, your emollients, huge list of laxatives are there, and we will be frequently using this laxative. But always you should remember that when you are going to use a laxative, be very cautious. For example, if the patient is having coexisting IBS presentation, and sometimes IBS will be a mixed variant. It could be coexisting with your constipation, some patient will be having coexisting with your diarrhea. And when you're going to tackle with this laxatives, most of the time this IBS may get worse. So that's very, very important for you to get addressed. So you'll be initiating the patient on laxatives. He might be complaining. So I'm having more of constipation on these occasions. I'm having more of diarrhea on this occasion. So the presentation will be more of constipation. So you'll be initiating the patient on laxative. So what is going to happen? Immediately some patient will have more of diarrheal events. At that point, you will need to treat the diarrhea rather than tackling the constipation. So this is what the commonest adverse event been reporting when you are going to use your laxative. So choosing the laxative is important. And before choosing the laxative, you need to rule out any evidence of obstruction. For example, soda obstruction. What is it called? It's nothing but Ogilvy syndrome. In case, for example, if the patient is having diabetic for long-standing duration, if the tummy is going to be too flabby, and if he couldn't able to walk, sedentary, immobile, depressive patients, and morbid obesity, so many complications you'll be frequently encountering. To that kind of patients, if you're going to put only laxative, the patient will be frequently, the rectum is going to get low, there's too much amount of stool, but it's not going to get empty out. So gushing will not be there. So at that point of time, the patient will have further worsening of symptoms. For example, the bloat, the electrolyte disturbances, the other presentation, your nausea, vomiting, so many other complications. At that point of time, the patient may take on. So how to go and address that? That's very, very important. So not all patients to tackle, only medications won't be suffice to tackle a patient with constipation. That's the most important thing I would like to convey before winding up. Next to that, regarding the common molecule, right now even the organizers been looking main to the prime talk of your procalypride. For example, when you go into subject, there are so many other second line molecules apart from your laxatives now being tried. For example, your procalypride, linaclotide, lubiprostone, plecanatide, they are going to bring into the market soon. And next to that, your chenaprel, your hydrogen potassium agonist, so many other molecules being tried. Apart from fecal microbiota transplant being tried in few centers in India, one in AEG, apart from that AEG in Hyderabad, and next to that SGPGI in Lucknow. What is a fecal microbiota transplant? In which the patient's own feces, they are going to centrifuge the sample and they are going to inject and they are going to ingest. So at that point of time, you need to see how for the response. There are so many studies are there to prove that in the management of chronic idiopathic constipation. But that's not the area to discuss much. You should remember that before winding up, these are all the modalities. So many other innovations and interventions are being acted in the field of gastroenterology to look for evidence of constipation, how to recognize, how to tackle. And your presentation, for example, if you're going to use your procalypride, it's nothing but your chloride channel activator. So when you're going to use that, I'll be showing you this flow chart. It's mainly going to select your 5-HT4 agonist. What is going to happen once your 5-HT4 pathway is going to stimulate, at that point of time, your peristalsis is going to get enhanced, your colonic motility is going to get augmented. At that point, all this movement, bowel movement, CSBM, that means your bowel movements, it's going to get enhanced. At that point, the patient is going to evacuate your stool. And this kind of things is being most safely recommended only predominantly if it is going to be slow transit constipation, or when you are going to tackle a patient with dyssynergic defecatory disorders, but not for normal transit much of role. But when you are going to tackle with laxatives, mainly for normal transit you can consider, but for slow transit and defecated disorders, this kind of molecules will be having more potential rather than considering your laxative, because laxatives in case of slow transit, at that point of time the patient may have further worsening of your fecal load, at that point the patient may have further worsening of symptoms. So these things should be promptly addressed, and newer innovations that being and newer investigations like your, as I discussed, your barium defecogram. For example, your MR defecogram has been taking a huge role, and biofeedback therapy, that is one thing we need to discuss. What is it, biofeedback therapy? Where those things have been doing or we are really practicing? To be very frank, in Tamil Nadu, biofeedback has not been drawn much high, but I have tried multiple patients in Apollo. Biofeedback therapy, we have been trying to some extent. What is this biofeedback therapy? It is going to recognize your output, your stimulant, your contractility force, all those things by impulsive generation, and it is going to track the record how far it is going to be successful. Ask the patient to assume a posture. For example, put the patient left lateral position and do a balloon expulsion test. What is going to do? Just put a balloon inside the rectum and inflate the balloon for 50 mm. At that point of time, ask the patient to expel the balloon on its own. If the balloon, if it is going to come out on its own, which means it shows that sensitivity is going to be good and the patient rectal contraction is going to be good, and if he is going to do that kind of exercise frequently, that's one form of biofeedback. At that point of time, the dyssynergic defecation mechanism is going to get improved, and the patient may have evidence of your constipation to get relief. That is what your biofeedback therapy and other things will enhance. Your various postures, because constipation is not only a problem for adults. You'll be frequently seeing in pediatric age group, we are being less than 12 years of age, they'll be frequently reporting with this constipation because the parents may not be aware whether the child is having evidence of organic or functional. At that point of time, this kind of modality, we need to see whether the baby is being responding to this kind of treatment. There are so many laxatives they will be prescribing just like that. I have seen recently also a young pediatric child who have been presented with a multiple laxatives for a longer duration. Is it so? Is it recommended? No. First take the diet, lifestyle, and the mother is still feeding the child with huge amount of bottle, milk, lactose and all those things. See, diet counseling, nutrition assessment, encouraging psychological stimulation, all these pointers to get addressed if you want to manage a patient with constipation effectively. That is what is important. It's not a single dimensional approach. You need to approach multi-parameters, assessing the patient as a whole, tackling the risk factors. That's the most important thing when you're going to manage a patient with chronic idiopathic focus of constipation. These are all the huge list of tests. For example, your defecogram, if you're going to consider, when you are going to see, for example, your rectal prolapse, your rectocele, other conditions, and all, you can able to identify very well with your defecogram. It could be either barium or MR and all those things. At that point of time, you can consider. For defecated disorders, you can do your manometry, rectal manometry. So at that point, you need to see your rectal pressure, how much it is going to get stimulated. That's what is called RAIR, your recto-anal inhibitory reflex. So all these things you are going to measure to augment, to diagnose your problem. The recto-anal inhibitory reflex is one strong pointer to consider a diagnosis for your Hirschsprungs in pediatric age group, and also we are seeing some Hirschsprungs in adult onset presentation in which the initial event is not been recognized. So why do you want to see all those things clinically recognized in the presentation? And before concluding, one important thing is the golden finger rule you should not forget, because the digital rectal examination. The one important thing, if you are planning to attend a PLAB or any exams or OSCE in any scenario, at that point of time, the digital rectal examination itself is one of the difficult and toughest tasks to be followed, because if a female patient, for example, the bystander counseling, the bystander has to be informed, and we need to make the patient semi-naked and put the patient in prompt position after wearing the gloves, and prompt moistening of your hands and putting the patient promptly and not directly into the anal canal. Like that, transversely you need to go, and then we need to slide up in. All those pointers carry separate marks. Why I would like to point out that digital rectal examination, the inspection as well as the palpation will diagnose your 50% of your problems. For example, your local complication like your hemorrhoids, fissures and all those things you can able to identify to some extent with your digital rectal examination. That is what the golden finger rule theory in the management of constipation is always important. See for the gush of stools, see for the lump of stools, see for the alarming picture, see for evidence of bleed, melena, abdomatochesia, any other presentation, alarming signs. That's very important. You are not supposed to forget. inspection, palpation, prompt consent has to be taken promptly when you are managing the patient with this constipation. So clinical recognition, history taking, examination of alarming pictures, and rule out the basic investigations, tackling with the molecules, and choose the molecule right proportion is the most important thing for you to manage a patient with chronic idiopathic constipation. With this brief discussion, I'm happy to rest my presentation, and if you have any doubts, we can discussion is open to the podium as of now. Thank you very much. As of now, in prucalopride, any 5-HT4 agonist, madam, they have been considering as a cardiovascular major event. That's the most important thing they would like to address. And there are so many papers here to prove that. But cardiovascular, what they've been considering when compared to other molecules like azathioprine and tegaserol, which have been abandoned in the market in the initial phase where they've been tried. Now, with your prucalopride, it's not much of adverse event for your cardiovascular potency. But apart from that, some minimal nausea, bloating, and vomit and other symptoms been reported. But as of now, the huge amount of electrolyte disturbances and cardiovascular renal intoxication, there's no papers to document significant representation as of now.
What about the cinetapride,
Sir?
Cinetapride.
Cinetapride. Cinetapride is a prokinetic which is being very safely used, but not primarily for the diagnosis of constipation. When you're going to tackle your molecule with cinetapride, that's also be a 5-HT4 pathway, but it's very safe molecule for the gastroparesis. If you're tackling a patient, for example, diabetic gastroparesis, the best potential molecule will be a ichopride. Next to that will be a cinetapride in the market. So you can tackle very well with your cinetapride, but as of now, for considering the patient with this constipation per se, it's not much of a recommendation. And regarding a prucalopride, what is the best line, what I would like to point out, I forgot to talk in this discussion. So prucalopride you can even consider for your diabetic gastroparesis because the potential role will be stimulating even the upper GI tract rather than mainly considering only for the lower GI. But how far it is going to be successful in India, not much of potential studies are being to prove the beneficial role because constipation, even in gastroenterology, is very huge list of task force guidelines are there. One is American Society, one is European Society, one is Korean Society, so many guidelines are there. The task force guidelines, Indian guidelines, it's very difficult even for the best of gastroenterologists to remember all those concepts. Why I would like to point out this, tackling with minimal medications, assessing the patient as a whole is very important.
Does it act only on the GI tract or does it act elsewhere in the body also?
Sir, the predominant area of involvement is within the GI tract. It will be acting on other areas where there is the HT4 stimulation. It will be acting on cardiac in every area, but the potential stimulation is not been much higher. And there are mild evidence of QT changes being reported even with the prucalopride, but it is not very significant potential enough to cause side effects.
Is there any interaction if sildenafil is used simultaneously?
Possibility might be there, sir, but I have not tried that molecule to my level best.
Because the patient is taking
No, but we need to be considered, sir, because sildenafil is a molecule which will be acting on a cyclic GMP pathway. When you are going to take your other molecules, for example, your lubiprostone, your linaclotide, these are all will be potential enough to act on CGMP. Those molecules will be having more interaction rather than considering this prucalopride. But my area to discuss with prucalopride along with sildenafil and not being much routinely being used in that kind of scenarios. Better avoid sildenafil safely. Considering pulmonary hypertension, okay. Pregnancy, prucalopride, okay, but not other molecule. For example, if you are considering lubiprostone, it's a category C drug. Prucalopride, it's safe. Not safe, it's okay, but it's coming in the category B. But category C is lubiprostone is not safely recommended. Prucalopride you can consider for pregnancy.
Even in the first trimester.
First trimester, ideally, no molecules to be considered, madam. That's the main guidelines as per my clinical experience, what I'm telling. See, first trimester, always a constipation will be more common. Moreover, as the age progresses, as the scenario increases, at that point, the constipation will be more, because the pubic rectal is going to get wider at that point of time. Some might be having a minimal improvement, but first trimester and third trimester, we need to be very cautious rather than using this kind of a potential GI stimulator. No.
But usually in pregnancy, it's because of pressure of the uterus on the colon, more likely.
Yes, sir.
So in that case, you would like to give something like lactulose, something which is more
Pregnancy,
of a-
very, very safe molecule is lactulose. You can directly give, but only thing you need to address whether the patient is going for diabetes in pregnancy. At that point, lactose sometimes may have worsening of events.
Yeah. So children's we can use.
Children's procalyprate, no much of guidelines, sir. Above 14 years of age.
Above 14 years.
Of age.
And they say elderly reduce the dose to 1 milligram. No?
Elderly, in case of renal intolerance, not much of guidelines, sir. If it is more than 80, if the patient has renal intolerance, at that point, hepatic clearance, if the patient is on diuretic, liver impairment, cirrhosis, already the patient on diuretic support, at that point, cardiac molecules, you should be very, very cautious. Because they are all activators.
So the stools like pellets like stools.
That's based upon your Bristol chart, sir. That's what I'm telling you. So Bristol, I didn't show all those things.
Along with this, we can add another laxatives.
You can definitely add laxatives based upon the presentation. That's what, sir. But ideally, I'm seeing some patients who have been using flucaliprate up to 4 milligrams of dose, and some consultants have been prescribing flucaliprate along with lubiprostol. Adding multiple molecules will not going to yield you much benefits. Adding multiple molecules will make you to have more complications. So, addressing the patient diet, lifestyle, coexisting complication, comorbid presentation, that is very important when you want to tackle these events. Any other questions to get addressed?
Safety in multiple comorbid conditions.
So-
Hypothyroidism, diabetes.
Hypothyroidism, diabetes, all those presentations will be having evidence of a gastric stasis. That is what we have been discussing as a gastroparesis, which will be briefly coming to the diagnosis of FGID. At that point of time, you can use safely this flucaliprate and other molecules, because the patient will be most of the time will be landing up with the evidence of slow transit constipation. So that is very, very safe. But apart from that, cardiac molecules, risk factors, cirrhosis, fluid overload conditions, it's always a questionable issue, and the studies are not been well documented much to prove on the beneficial effects.
So diabetes, constipation in long term can be either due to diabetic gastroparesis or due to the fact that many of them are using metformin.
Metformin, rather than
Long-term.
predisposing for more of constipation, those kind of patients will be having more of diarrhea, because metformin is one of the common molecule, best of molecule for diabetic presentation, but it's one of the worst of molecule in tackling a gastroenterology practice. Because all patients who are on metformin, there is high possibility of the patients to land up with evidence of irritable bowel, and the patient may have evidence of diarrheal presentation. So the offending molecule has to address first. The metformin has to stop first, and then only we need to tackle this kind of events. But these are all assumptions and guidelines being proven. But how far you are going to be successful when you are going to manage, it's still the tip of iceberg has not been pointed. Is still we are not able to see, we are not able to recognize, and the investigation cost is too high. For example, if the patient wants to go for defibrillator, if the patient wants to go for wireless motility capsule, if the colonic transit, how difficult is this? Colonic transit, for example, I didn't talk much into that area because it's purely theoretical. Colonic transit, if you want to do, the patient has to be visit the hospital at least 5 days, and then they need to take at least 24 markers, and 6th day you need to see whether 5 markers are being there, in which area it is being there, whether it is the right side of the colon or whether it is the left side of the colon, and all those things has to see promptly, and after that the molecule what you are going to use the same one. These things only you need to address. So assessing, diagnosing is okay, but how are you going to recognize it matters a lot.
So the diabetic patient in pregnancy or constipation, what do you suggest?
Diabetic patients in pregnancy for constipation, first thing I would like to suggest, don't give any molecule. Just assess, weight, counsel, diet, lifestyle modification with good fiber enhancement, whether the patient is having supportive improvement or not. But if the patient is having significant constipation, more than 7 days of retention, not even 1 or 2 bowel movements, at that point the safest molecule will be your laxatives. At that point your osmotic laxatives will be safely added. At that point you can consider lactose and other support, rather than considering your bulk forming, your mineral oil and other things, because those things will have further electrolyte management disturbances and some rare reports of fecal intoxication, all those things when fetal intoxication. So be very cautious when you are using other molecules rather than considering, because these kind of molecules there are papers to report your to cause your ileus like presentation. So you should be very cautious at that point of time. Rather than landing with complications, better not to use multiple molecules. Sir? Lactose, lactitol, all those things you can consider. It's osmotic pathology. I mean osmotic
It is
disease.
on Senna and Kuwait, sir.
Senna Plus is a stimulant. Senna alcohols you can use, but that's a stimulant, and you will be having CNS intoxication. CNS, when you are going to use that Senna derivative, your anthraquinolone based derivatives, all those things will be having a CNS events papers reports are there. Why do you want to try with Senna rather than we are going to have a multiple other molecules? But Senna you can consider along with the lactitol and other presentation, but isolated Senna, as per my guide, as per my opinion, it's not much of recommendation for regular usage. Same one, sir. Everything, whatever you are going to use a suppository or oral, whatever you are going to try, the same physiology of action to be considered. And moreover, when you are going to use suppository, you should be very conscious that the patients have ideas and other thing. At that point, no. Any other questions to be? If no other questions, I'm happy to rest my presentation. Thank you all for patiently. Check. How are you, ma'am?
So I would like to invite Winston Anna sir. Sir has actually launched Prochlorpride in Chennai. So we have sir's presence today. So I request sir to have some words on Prochlorpride.
I thought you were going to ask me to give.
Yes.
I think after Dr. Arun's talk, we don't need to add anything. But I was discussing Prochlorpride with Sir just before our talk, and he said that the main thing is we have to start on 2 milligrams, sometimes increase to 4 milligrams, and you have to give it for an adequate length of time. It's not like when you give Dalcolax 2 tablets and patient passes motion. You have to give it for about 4 to 8 weeks, 2 months. So that's the take-home message, that it's going to act slowly, and you have to wait because it's going to modify the physiology. It's not going to be an immediate action. Like you drink 15 ml or 20 ml of Crimafin plus or something, and you immediately next morning go to pastoral. So that's the only message I have got, and I think that's the message I can convey to others. It's a good molecule in selected cases. As every case you're not going to be, suppose you have small pellety motions, you obviously will need to give a little more bulk to the stools. And I think the important point that was brought out is, whenever a constipation, since I'm a surgeon, rule out first a surgical problem. Many times you give laxatives when actually patient is having some surgical problem, some obstruction, subacute obstruction. I have seen patients who have landed up in acute obstruction because somebody didn't recognize the problem. So these few words, I think nothing much to add on this because the talk was quite good. But as a surgeon, I'll add the surgical perspective. Thank you, sir.
I request Winston Anna sir to felicitate the speaker.
So good afternoon, doctor. I'm honored to propose the vote of thanks to today's CME program on behalf of Torrent Pharma Prima Division. I would like to thank you, our speaker, Mr. Dr. N. Arun sir, who has given a wonderful talk on idiopathic chronic constipation. Sir. And next, I would like to thank all doctors who have come and attend the CME program. So once again, a big thanks for our use. Lunch is there. Thank you, sir.
Sure, sir.